Hello and welcome to my presentation in this One Health Day webinar. I'm very pleased I hope you find what I have to cover interesting, and I apologise in advance for the headset, but I find that's the best way for my setup to get the sound across. I'm Associate Professor Simon Reid from the School of Public Health at how I use One Health in practice and some of the issues I've encountered as I've tried to make use of the tools in the toolbox of One Health that I think are there. And finally, I'll provide a case study on some work we're doing in Fiji. So, in terms of the content, what I wanted to do was put a few issues out with regards to One Health, and particularly around the need for better collaboration and better structures for collaboration across sectors. One of the tools that we use more and more that some observations on how effective intersectoral in Fiji, where we've been able to achieve quite good collaboration. So firstly, some issues. Now, definitions, I think the issues I wanted to raise really were that a lot of what we understand is framework, and if we look at this is taken from the One Health initiative, and One Health's considered this umbrella underneath which are the various sectors of health and sectors of scientific endeavour. So we've got everything from ecology to environmental health and public health, and then underneath there are these sort of linked issues around the health of the population, the health of the individuals and the ecosystem, and we've got our issues in boxes. Now, I find this quite a complex diagram. It's quite hard to digest. It also really what we do. If we then look at the traditional way of viewing One Health, which is this sort of Venn diagram of overlapping areas of concern with the human-animal ecosystem interface, I mean, that provides a much simpler but perhaps too simplistic view. One Health doesn't necessarily sit neatly in between these three zones. And whilst it's easy to explain, it does actually make it difficult to then explain what to do. And I've taken this definition from the AVMA website just to go through, and what I've done is highlighted the words that I think are important. So integrative is essential. One Health is about integration of policy and practice. It starts to me to become difficult to work when we talk about multiple disciplines, because we really are framing it in a scientific context. We also start to look at the role that veterinarians play, and this is of particular interest to you as a group of students studying veterinary science, and that is that we look at whether this area is overlooked and unrecognised, and certainly I'll give you such and then we've got this sort of statement at the end that says that veterinary medicine is the only profession that routinely operates at the interface of these three components. And I would student type approach, which is essentially the framing for this comment. The veterinary profession has a very important role to play of what I call hazards at the human-animal. I think to get your own understanding of how you work across sectors. The reason I know this is because my training is as a veterinary surgeon. I did and understand ecology and ecological principles, but I graduated making a sideways transition into working actually in the field of public health. So I feel that now from most of the different perspectives. What was interesting to me was gradually getting this is definition of environmental health, and the reason I put this up is that environmental health actually is a much I guess much closer framing to this concept that works, or the professional group that works at the human animal. That's because human and public health at that environment interface, and animals are part of the environment. The environment is not separate from animals, and so this is why I challenge the Venn diagram, because I don't believe we concept from the animals that are within it. So within public health. So all of the work that we do in One Health, because they are the professional body who are primarily responsible for implementing food safety regulations. They're interested in environmental hazards. So I guess I'm putting this out there just as a way of explaining to you not to I guess buy in too much to the disciplinary boundaries that are established in some of the statements that are made. The reason for that is that this really felt was important was that these are the in terms of One Health, these circles represent the interrelatedness of the communities about the communities, so the veterinary scientific community, the ecological community, and this third group, which is made up of a much broader group, largely working in the field of public health and to a lesser extent some of the sociological sciences. Output, the number of publications in One Health in this third grouping is expanding rapidly, and this group is inherently interdisciplinary because they are working in interdisciplinary fields of public health. And ecology is largely, a lot of it's around conservation, so the concept of eco-health. Scientific clusters are keeping ourselves separate, so we're not reading and cross-referencing work from this other more dominant group. And I think this is an illustration of what we see in practice. And so in my experience, the veterinary profession understands One Health, they understand the ecological issues, but there's some sort of and some of these are institutional in that it's very difficult to publish outside your field, so we have some issues there. But I think there's also a matter of where we set our boundaries around what our areas of interest are. So one of the tools that I find most useful when I'm sort of presenting a One Health approach is systems thinking. And systems thinking isn't a new concept, it's relatively well established in business. Systems it's also not foreign to the discussion around One Health, and this paper that was presented by a group that did a series of extensive consultations have identified that systems thinking is one of the key domains of competency required for a person who chooses to work in One Health. Are fairly generic, but they really relate to the ability to work with other groups of people. Systems thinking is quite different to that in some ways, in that it is an ability to think holistically about the problem. And the need for this sort of more holistic understanding of our problems was summed up in this document, and it comes from a global health consultancy firm. It's not anything to do with One Health, but when I read the text, I really felt that it just face, and they talk about the convergence economy, and this is where issues are converging. So everybody's experience and exposure and responsibility for issues stress the need for integrated approaches, which is exactly what we're talking about with One Health. And so this is an excerpt of their comment, the commentary within that document, and they pose this question of, will we solve yesterday's problems? And then they're saying and structures that we already have, and this is not unique to this area, and it's a reframing of that. You can't solve yesterday's problem with yesterday's thinking. But what communication and cooperation, it's not the same as collaboration. What we need then is this integration of effort, and that comes when we understand that the issues are shared, and I know that is the understanding, but I think what we in One Health. The reason for that is we've really got to reframe the way we think about our solutions, and is this table in this publication, which comes from a systematic review of all papers that address emergence and re-emergence, are most important in my mind, and they are inextricably linked, because obviously a change in human society leads to a change in land use. It's inevitable, because we require the land to produce our food and to provide space. And these are not specific issues. They are fairly broad and system-wide issues. So poor population health, and that's also linked to issues of poverty and environmental contamination, and so we've got a series of issues that are interrelated. If we then put this back into our Venn diagram, and this is, to me, a much better way of viewing the problems of One Health, and that we have a series of interrelated systems, and this is what I'll talk about in a minute with systems thinking. Of zoonoses occurs as a result of the interrelationships between these different systems, and I think if we frame it in terms of the human system, the natural system, and our agricultural systems, it gives us a much better understanding of how to begin to explain how issues arise within those systems. Theoretical framework, and is more than theoretical, because there are some very good solid tools that are used in systems thinking that we apply directly into One Health. in a traditional scientific disciplinary degree, where reductionist means you break things down into their component parts and you focus on those components. So in epidemiology we focus on risk factors, we focus on demographic factors, we break down causal pathways into individual variables in our elements. We look at the liver in the body systems as an isolated organ, even though it's a supply of nerves and chemicals as well as blood with other organs in the body. So the human body is a system. We cannot isolate out a piece of that of the body. And it's the same with a system that leads to a zoonotic disease such as salmonellosis. You can't isolate out one system, get an understanding of that component and know how to solve the whole problem. Relationships of components. So how does a system work? And as a result of that, we start to look at things that are understand how it works. We want to understand how to manipulate that system, how to make changes to the system. And the reason that we need to do that is because you can't just expect to get a major outcome in the way the system's performing. And so my concept of system performance is disease incidence or disease risk. So we can't expect to change the food safety system simply by focusing on legislation. Change reduction of cases of foodborne illness, but we will not solve the problem. It's important to know then that when you think about these systems, there is this difference, and so we do a lot of in our disciplinary reductionist thinking. So causal pathways are by their very nature events as loops. So there are loops where things are getting worse, so reinforcing loops, as well as feedback loops that moderate the behaviour of the system. And so therefore we're looking at the causal relationships within the system, not just things in London. So Yersinia it's not, sorry, I don't know the name of it now, but it was Yersinia pestis. So we're dealing with a zoonosis carried as the amplifying host are rats. That basically posited that the London plagues were 200 years in the making, and that there were 200 years of events leading up to the system that generated the plagues. And so to get an epidemic, that's the outcome of a system. And over a period of about 200 years, London went through an economic boom. It was the centre of international trade in the known world. So boom, London became more crowded. There was a very large increase around London. And more importantly, as people became wealthier, they wanted to eat more meat because eating protein was income. So protein is a valuable nutritional source of nutrition, and it's also a sign of wealth. Eating meat in a time before refrigeration meant that more animals had to be carried into the city. those animals need to be fed with a cereal-based diet, which then breeds more rats. And all we then required was the introduction of the plague bacterium into the rat population, and this was achieved through international trade, and I'll show a slide in a minute. Then there was this complex together to generate the risk profile in the population, and so plague was the interesting thing about the London plagues was that it moved at the same sort of pace as an ox and cart. So the transport at the time was animal based, and that's essentially how plague moved. Now, what's interesting is that people have looked back now and using more sophisticated molecular how plague moved, and essentially as trade in London growed, where a lot of the goods that were traded also grew, and so plague was reintroduced in camel trains into Europe, and then established a series that were ready to receive and to disseminate the plague vaccine. So the issue with plague wasn't just simply about a public health issue of trade and economic development. So when we look at a solution, we might actually start to look at talking to different people about the solution, rather than just keeping it within our own disciplinary and professional boundaries. The reason I think this is important is that time China is in Guangdong province, which was where SARS first emerged from civet cats. And when SARS actually was all about economic development, and about a 40-year period of rapid economic development after the opening up of the markets in China to the outside world. And he said what's important is that as people in China, in Guangdong province, who are largely Cantonese, ethnically, their way of displaying the wealth was to eat more exotic meat, and that meant civet cats, different types of birds and mammals. And with that, the trade in exotic animals and live animals boomed, and we ended up with a very chain for these exotic animals. They were largely slaughtered at the point of consumption, so the industry just the same type of comment as the comment around London. And so what it means is these system, rather than this simplistic view that this is a food safety issue. So I just want to cover now, having framed how I see One Health, I just want to talk about a few issues that arise with trying to put it into practice. And here I'm talking about an example of antimicrobial resistance. So the AMR is of global significance, and it's only the 4th time that the United Nations has actually made this type of declaration for a health-related topic. The last time was HIV and AIDS. Or more important than HIV and AIDS through this declaration. And they specifically call for One Health approaches with FAO and OIE. And the important thing is that it mandates that every country has an intersectoral collaborative AMR. Australia generated such a strategy using a One Health approach, and they had collaborative workshops to develop this. It is jointly endorsed by the Minister for Health and the Minister for Agriculture. So this is the first time that this... And this document is that where there's common agreement about how the system of AMR are well written but fairly poorly articulated across species. And what's interesting is then to look at the leadership, and so part of One Health is also leadership, and we don't have in Australia strong leadership around AMR, and we have issues about how much responsibility each grouping or each professional group productive as a tool as it could be. And so that's one of the issues we lack, is that leadership concept. At a more within the system, so zoonoses, is quite challenging, and what I've done is extracted out a few years of Australia, and we have the highest rate of zoonotic disease reporting in humans in Australia. And I took the complexity, and it's complexity from the point of view of response. The list that we have include brucellosis, which is mainly Brucella suis from pigs, and we have a large population of feral pigs or wild pigs that were domestic pigs released into the wild. So this is recreational exposure or professional exposure through pig hunting, and we see cases in dogs, and we see cases very specific issue, but as a result, it's a very specific than the human health side. We also have issues around Campylobacter and food safety issues, and so this is the poultry industry. We have issues with E. coli, and the last large outbreak was related to through livestock, through cattle. Leptospirosis is a perennial problem, and there we're dealing with rodents and systems as well as recreational use of surface water. We have a disease, psittacosis, from our psittacine, and many of the cases are in people who live in semi-urban areas or live in areas where these birds are common. And some of the examples we get are people mowing the lawn. They mow a lawn under parrot roosting. They aerosolize the chlamydia and abattoirs, as well as people working on farms or and then we have Ross River virus, which is a zoonotic arbovirus. It's often marsupial host. So in Brisbane we more or less all around us. They live in people's roofs, they within our houses, and complex. And so if we then look at it from the sectoral point of view, so who's responsible and where does the solution lie? Now, if we look at brucellosis, it's not really a big issue for human health, but it's persistent enough in high risk groups that they're concerned. In animal health, it's a bit of an issue for dogs, but in our government system, dogs really fall outside the main area of interest for our veterinary workforce in government, because it's mainly focused on animal health in terms of animal production. So it's of importance to dogs, but it's a challenging one for them to justify resources. And then if we consider the environment, well, it's hard to articulate because it's an exposure through to get Bruce engage with government authorities. So the discussion around brucellosis is quite different to the discussion for Campylobacter. So here we're dealing with a highly important. We see a large number of cases of Campylobacter. A lot of legislative issues because it's a food safety issue, particularly for restaurant owners. So the human health and the environmental health workforce are very much engaged in this at all, because this is seen as a problem that's solved through regulation, and the same goes for the environment. Because of the way that we conceptualize the solution, which is enforcement, nobody else really gets involved. So the question I have is, what else could we do if we extended the responsibility out into other professional groups? The same goes for E. coli. We have some legislation about different food products, but it doesn't cause a problem for animal production. So there's an ongoing collaborative involvement with animal health authorities. There are specific groups of animals, there will be collaborative activities, but these are not what I would consider to be sustainable intersectoral collaboration. So leptospirosis is again a bit like brucellosis. It's a very sort of complex disease. The causality is complex. It's hard to measure the impact in animals, but it certainly has a high profile in some particularly dairy animals, and it's partly from occupational health and safety for the animal workers, as well as from an animal production point of view. Whether you can actually do anything about that is challenging. Rodent management is never systematically done, and there's no real evidence that would point to a solution in the environment. I'll go through lepto in some detail in a minute. So again, talking about ornithosis, it's a native species, it's wildlife. What else can you do? However, it's an issue specifically for human health. Q fever is a bit the same, without any special circumstances like the new introduction of the pathogen into a naive group of animals. You don't see any clinical disease in humans, in animals. And the interesting thing about all of this is when you sit down with a group of people who talk about common interests, and we did this here in Queensland, and we went through this list, and the public health people would say, yes, food safety is really important to us. Animal health would say, not a priority. We got to Q fever. Q fever is important, we really need your help. The response from animal health is, well, it doesn't cause a problem in livestock, so therefore we don't have any sort of experience in working with. When we get to Ross River, it's the same, and so what this table really is about is the conversation problems. So what I want to show you is an example of the process that we've gone through in Fiji to address one of these issues that has . And this is set in Fiji, so just skipping ahead. So Fiji is it's an island country with 300 of and there are different zones, and so this is the two main islands where most of the population live. And you'll see from the colour that there's a line that runs diagonally through the country, and this represents different climatic zones which then have an impact on the agriculture. And so we have more open grazing on this side for cattle with forested areas, and on the western side we have cultivated sugarcane and other cropping because it's a much different climate. So what we're interested in is leptospirosis, and really this is I guess we start with a focus on the bacteria, and this was how we approached as a team of and human health. We approach this from the point of view of the bacteria. So this is how we conceptualize what the bacteria does. It moves around within populations and it moves between populations, and then if we look at those populations of dogs and humans, it then has a clinical impact. And we can start to identify who these groups are. So we have occupational exposure as well as recreational, and we don't know about the relationship between dogs and humans. So this is a traditional epidemiological point of view. And what we did was we moved through the traditional forms of study, science. We looked at that there's on average about 400 cases a year, and about 35 to 36 deaths each year. So it's quite a considerable issue. And to put that in context, that's more deaths due to an infectious disease than all other infectious causes put together in Fiji. So that includes HIV and tuberculosis. So it's an important problem. It's in the newspapers. If we then start to look at patterns, again, we take our disciplinary lens and we start to break it down. We look at there's more males and females, which reflects the occupational exposure. In this western side, which has a different climate to the eastern side, we see a much more pronounced seasonal variation, and this just happens to correlate with some of the agricultural practices. We then look at the demographics, and Fiji is made up of two major ethnic groups. There's indigenous Melanesian Fijians, who are also known as Itoke, and then there are Indian people of Indian descent who were brought to Fiji to work in sugarcane as indentured labour. So because of the different occupational groupings and distribution of these different ethnic groups, we see a difference in exposures. So we see more cases in Itokes. We also see a lot higher death rate in Itokes. And again, people in work either through recreational exposure or as working age people. And there are some specific issues related to comorbidities and other diseases that lead to deaths in higher age groups. So what that means is we have some understanding of the sort of epidemiology. We know a bit about who's exposed, but we don't know a lot really. And so what we did was a couple of rounds of consultations. And so the government of Fiji, so the Fiji Ministry of Health, specifically asked for support to develop a multi-sectoral strategy to minimise the burden. So we put together two quite mixed groups to sit under. So we structured our workshops around clinical management. So this was mainly clinicians working in the hospital or working in the laboratories, both animal and human, agriculture, so this collected up people working in then environmental health and their role as the main communicators with people working. And what we determined from these workshops was that we need to reduce the mortality rate. So this is the proportion of people who are sick that die, and they felt that they could manage that with better clinical management, strengthen the laboratory capacity, and also strengthen collaboration between laboratories, so public health and animal health. Agriculture, they need to look at reducing leptospirosis in livestock through a structured program. And environmental health, they're really focused on what they know best, which was managing the reservoir species. Okay. Now, you may know a lot. And so what we then did was we took a more systematic approach. So we then took a step back and we said, okay, well, let's look at the system. Will they respond to the problem? And we consulted with them within the government structure, from different ministries and from the agriculture. And the aim of this process was to really come up with a list of options. So these are management options rather than framing it in terms of the problem. And then to more importantly align that with existing structures within the ministries. Okay, so this is again, the organisations that are part of our system have to work within their own structures. So what we did was we went through the decision makers, and it's fatal, and it's such an obviously well-known disease. All of the concerns are about public costs, and that didn't really motivate people. Of the role of lepto in livestock information, and there are so many other problems in animal production systems. So it's such a unlikely to be a major contributor to poor production, and it's going to be years before the system is more about managing risks to humans, and from the animal point of view, for animal health authorities can assist in terms of how to work with different populations of farmers, and also how to contribute to the bigger solution. We also speak to people who were affected and who are cases or who had a death review solved, but they wanted information. They wanted to know how to manage their land, how to farm, how to plant crops, and do so without risk. They wanted to know about different options. So it's very different sort of framing to the other side of the problem, which is the health side. So we then finally ran a workshop in BMC Public Health, and we tried to then reimagine how to look at this problem based on our understanding of the system. And we came up with a structure that was sort of similar to our previous action. Clinical management, surveillance, communication, or prevention. So those are the 4 areas that were in this plan. And so you'll see immediately that we've taken out the professional and the disciplinary boundaries, and we've looked at actually what has to be done again, we had to then put it in context of existing strategies, and so there is an existing strategic plans that run to 2020. So we came up and we looked at those, and we put this within the context of those plans. And we wanted to know also about feasibility. So this is why we came up with a ranking system for the different solutions that were raised by the workshop group, and they were things about cost. So did it need extra funding? Was it actually more likely to have an impact or less likely? Were we looking at how feasible it is? You know, what are the obstacles? And also, do we have the actual the human capacity to put these things forward? So what we then ended up with was a much more specific plan, and that was that we focus entirely on case fatality rate. So this is the mortality rate of cases, and we wanted to decrease it by 50%. The clinicians to manage cases better, but we want to know an awful lot more about cases, and we want to know more about surveillance, and we also want some information from animals. And so this improved surveillance includes collaborative investigations of outbreaks and cases. We want to know how to better change people's behaviours, so we want to work with partners, and so we identified different agricultural who could assist us in understanding how to communicate and how to change the knowledge and behaviours of different groups within agriculture. And again, this is also new to the Ministry of Agriculture, because they've never sat down together to work with these groups to try a government system. It's very important that we have a mechanism for managing this process and to ensure that collaboration occurs, because there's not a lot of incentive in to collaboration. The barriers that we've discovered mostly here in Queensland as well as in Fiji are that the public health need for collaboration is very strong. There's a need for them to reach out because they understand where their boundaries are. The difficulty they find is engaging with the animal health and other parts of agriculture. The problem but we work in a structure, we work in a professional structure that has very specific boundaries. When I was taught in vet school, we were really discouraged from the concept of thinking about human funding that comes for agriculture can't talk about human health. So we've set up these artificial boundaries which really make it difficult. And this comes home when you sit down and address this in a systematic way, because the comment is always, this is not necessarily part of our mandate as an animal health authority to provide human information in emergencies, but what we need in One Health is this sustainable, ongoing collaboration, because the mandate of the organisations prevents it. In Fiji, the legislative structure of the different organisations also prevents. So what Fiji are doing is moving from this plan for leptospirosis interface, and that's currently the work we're doing, and it's to try and understand how we build an evidence base to prove to the different organisations that they have a role in the solving of these problems. So just as a way of finishing then, I just wanted to show you that so before we did this exercise in Fiji, we focused very much on the bacteria and the epidemiological factors that move them. Now, once we've gone to this broader structure, we started to populate the epidemiology and bacterial life cycles, questions of the systems. And so what we're doing now is getting a much better understanding of who is in the system, what their perspectives are, what their roles are in solving these problems. It's a lot slower and harder to define because it requires policies and practices and procedures across these groups. It almost becomes a sociological exercise, and it's very difficult for a lot of certainly veterinary scientists and public health scientists embrace this concept of sort of fuzzy logic. So the lesson means people who are acting in senior positions in different areas to work as champions, collaboration across sectors, and how to get people to work together. We really need to avoid that sort of reductionist view. We need to think about these things more veterinary science, but there's also a need to take a step back and look at the bigger picture. Veterinarians have an essential part to play in the management of zoonoses, and I know I've criticised the veterinary profession a lot in this talk, but it's more a critique. It's looking at the barriers that we work within because of our own professional barriers. We don't see some problems as ours, we see problems as somebody else's, and as soon as we do that, we don't see our role in solving the problem. It will take over time a shift in the different boundaries that frame our different professions. The drive to embrace strategies to reduce antimicrobial resistance will force us to work in a is one of the hardest to engage, and it's partly because this allow us to embrace collaboration sustainably, and part of that is in the government sphere, it's funding. You know, a private veterinarian will not be paid for giving advice to these willing to consult a veterinarian on referral from a general practitioner, so a medical practitioner, if they had a zoonotic disease issue, say ringworm in a child. The vast majority, about 80%, said they would. We are now undertaking work to look at whether veterinarians would feel comfortable giving people advice about infection control and management of the risks related to their animals and their environment. Because do we as professionals? I think probably not. So therefore this is a forward-thinking issue. And I guess the final point I want to make is always remember, always be aware of this growing trend in One Health for veterinarians to remain isolated from the main body of science. And I think it would be sad to see that the veterinary profession, the veterinary science community, that it maintains its isolation from the rest of the body of One Health science. Anyway, thank you very much for your attention.